Okay, thanks very much, everyone. And we narrowly avoided some technical difficulties, so that's good. We're winning. As most of you all know, if not everyone, I'm Councillor Lucy Desneves and I'm the chair of the Health and Wellbeing Board here in Haringey. And I'm duty bound to tell you all that this meeting is being recorded for live and subsequent broadcast via the council's internet site. So I welcome you all. Got some cabinet members in the room, council officers. You can see Jeffrey from Bridge Renewal, and a few others besides our NHS colleagues. So welcome everyone. Now, have you had any apologies?
Helen Brown and Vicky Murphy for lateness.
And I know that Councillor Michael Carter needs to leave early today. And so when I come to the agenda, we're just going to vary a little bit. So we take a particular item when he's still in the room. We'll leave him about 20 past 3. So thank you. Do we have any declarations of interest? And I don't think we've had any questions, Deputy Petitions. So we'll go straight to the minutes. Does anyone have anything? Are they a correct record? Anyone got anything that they want to raise? About? Okay, I'll take that as a yes. So we've agreed the minutes, and we're going to go straight on to what I think I'll do with the agenda is I'll take item 8, as I promised at the last meeting, and focus and give up prominence to our work. Then we will move to item 11. If we've got Paul in the room, so that's fine, and we'll take that item while Councillor Carter still. That's okay. But for now, let's go straight into item 8. Christina.
Thanks, Councillor Desneves. I'm just going to share some slides with you. So I was asked to just give a bit of a kind of refresh of the overall partnership programme plan, because I know we've spoken about sort of constituent parts of it quite a few times over the last few meetings, but just to remind everyone sort of what the whole thing looks like. So the plan was put together a couple of years back now, and its aim was to provide oversight, challenge and sort of maximise impact across the partnership on the work that the respective organisations in Haringey are doing to tackle racism. It took a thematic approach, so 8 key themes which cover most aspects of a resident's life. Each theme has 2 to 3 theme leads from across that partnership, so kind of key decision makers from different sectors, services and organisations. And in terms of the governance, the coordinating group addressing racism meets on a quarterly basis, and that's co-chaired by Jeffrey, who we have on the call, and Andy Donald, our chief exec, bringing all those thematic leads together. And that ultimately reports into the joint Health and Wellbeing Board and Community Safety Partnership on a 6-monthly basis. So we'll be taking an update to that next meeting. So just a reminder of what those themes look like. We have policy and strategy, which I'll talk a bit more about shortly. Health and wellbeing theme. We've had quite a strong focus on access and outcomes in mental health there, as well as a range of community networks that have stemmed out of that theme. Education and attainment, one of the key things we wanted to focus on was improving engagement with Black and ethnic minority parents in the borough. Community safety and policing, that theme I'll speak a bit about shortly as well. Arts, culture, heritage and place. So we looked at mapping diversity in our arts and culture sector in Haringey. Faith and identity. Took quite a strong focus on hate crime in that theme, and I know that there's the strategy development that will kind of run alongside this programme of work. Economy and employment. So we wanted to understand what Black business engagement and ownership looks like across the borough, as well as use of different spaces. And then finally our workforce, which we'd like to take more of a focus on going forward. So kind of understanding what that looks like, what progression pathways look like, resolution around discrimination cases, and awareness raising of equalities issues. So just wanted to focus on and pull out a couple of key bits of work that we've done through the plan. So one of the, I suppose, foundational conversations that was had when the group came together was around data collection and how we understand our population locally and what issues they face. So the policy team led on a piece of work to update our ethnicity and nationality categorisations. And that came as part of a wider review of the equality monitoring forms that they use. So those categories were reviewed for ethnicity and nationality, and that was informed by the ONS's standardised categories, so that we've got a level of sort of comparability regionally and nationally as well. But in addition to that, the team had engaged with local stakeholders to make sure that the categories were as fit for purpose as possible. And I suppose recognising that we're never going to get to a position where we can capture absolutely everyone in a way that's going to be sort of replicable and practical, but we wanted to get as close as possible. So one of the key issues that we had with how data was being captured previously, for example, was this white other category was capturing Turkish, Kurdish, Polish, and many other white communities who are kind of badged as white across the borough. And we know that we've got really significant Turkish and Kurdish populations, for example, large Bulgarian population. And so for those to all be placed in this catch-all just wasn't giving us the level of detail that we needed to understand strengths, issues, and make sure that we were supporting them properly. So those categories were reviewed and developed alongside a new equality monitoring policy and guidance. So that they've been approved and published internally for us at the council. And now what we'd like to do is have another sort of push on all of our services using those internally. So we'll be going to an upcoming leadership network meeting just to do a reminder and make sure that everyone's aware of them, but also want to work towards having a more standardised approach to how we capture ethnicity and nationality data across organisations in the partnership. We know that might be a bit tricky with certain groups, so the NHS will have certain ways of capturing data. We know the police do, but really want to start a conversation about how we can standardise as far as possible. So the second kind of quick update I wanted to give was on the mental health training that has been delivered between Mind in Haringey and Haringey's police. So this felt like a really nice sort of journey piece of work that demonstrated being quite data driven, finding solutions, and then this training ultimately having been delivered. So it was the aim of it was to improve cultural awareness and skills in our local police so that they could better respond to people in mental health crisis, and particularly Black residents. And also we wanted to make sure we were supporting officers to navigate systems, so tapping into intervention earlier where possible, and to look after their own mental health, because we know that has a knock-on impact. If they're experiencing lots of trauma and don't know how to deal with that, that will affect the interactions that they have with our residents when they're out at work. So we first got some really robust data on the really significant racial disproportionality in our mental health system, specifically the use of Section 136, where we saw disproportionate use with particularly young Black males, and particularly in the east of the borough. And that first bit of work was done through the BAME Equality Working Group. We worked with the police to get more granular data on that picture. So we went kind of postcode by postcode with them. So really good partnership working just in terms of understanding what the picture looked like as a starting point. And then we were able to secure some funding, so 43k through Health Education England, to deliver mental health first aid training to local police officers. And that was delivered by Mind in Haringey last year. So they've just about finished. The last sessions were held in December. They've now trained over 190 police officers, mainly in Haringey, but some Enfield officers came over because of the sort of crossover and shared borough command unit. Lynette will be going on to train 2 further officers as trainers so that they can continue to cascade that learning, and the insights from that training will inform the next steps that we take. So we always knew that one of the key bits of work we wanted to do was talk to people who actually have experience of being sectioned by the police under Section 136. So that's one area that we need to take forward. But the police also highlighted some other kind of logistical and partnership working issues that we'd like to look at next. So we're just kind of going through the process of mapping the journey of that training and doing some evaluation so that we can decide what our next actions will be. So more broadly across the programme plan, we're looking at refreshing the actions we're taking for the next year. So we've got a meeting coming up at next Tuesday. Is the next coordinating group that will bring all those theme leads together. And we agreed last time that at this upcoming meeting, we will define what the vision of the group is, so what we're aiming for collectively and what the particular power of the partnership is, kind of alongside and in addition to what we're doing individually in our own organisations. We agreed that we needed to have a really clear definition for the kind of reason that we're doing the work, so that we can confidently describe why race is being prioritised. We wanted to do some work on our role as leaders, so what that means for the coordinating group itself, our respective organisations, but also what impact our local residents will feel. And then importantly, looking at reviewing the objectives and actions that we're undertaking in each of those themes, following on from some theory of change work that Jean Taylor from our policy team had been leading. And another kind of key issue that was identified was the need for a communications plan, because we don't have anything kind of outward facing at the moment on our websites. And if people don't know we're doing the work, they can't engage with it and kind of help to influence it. So that is something else that we will be looking at taking forward. So we should kind of have some agreement made on those points next week, which we'll be able to share back with this group. And then, as I mentioned earlier, we wanted to have a focus on kind of internal practice and workforce. We agreed across the partnership that we all need to kind of look at what we're doing in our own organisations as well as what we're doing collectively. So one of the key kind of issues that's been highlighted is around representation. One example from quite a bit of the work that we've been doing not only with Mind with police, but more broadly, is mental health service practitioners and therapists, and kind of lack of representation of Black therapists, needing to address that. Looking at our HR practices, so including things like recruitment and talent management, also how we deal with discrimination, bullying and harassment, and I suppose just nodding to the fact that there's quite a bit of thinking going on in this space already in terms of workforce. So I know that colleagues across NCL are currently working on their people strategy. So I think there are some really good opportunities for collaboration there and for us to do joint thinking and make some commitments collectively. I'm going to pass over to Jeffrey at this point to talk about the racial equity group, which sits under the health and wellbeing theme in the plan. So if I could hand over to you, Jeffrey.
Thank you, Christina. Thank you, Chair, for allowing us to kind of frontline this meeting. And I think, as Christina has been explaining, it's 2 years, isn't it? But we've kind of found ourselves deep into some of the actions and interventions. But what we're trying to do now is have a bit of time to actually rethink and underpin and get some shared understanding of some of the issues, which is what we're trying to bring to the next meeting, which is next Tuesday for the coordinating group. As you know, some of it can be as basic as kind of understanding racism, anti-racism, and what does that mean, and so forth. Now, in this particular one, which is the racial equity group, the full title is In Health and Social Care, and it follows up on the health and well-being theme. So here, our next meeting is, we kind of meet 3 times or thereabout a year, and our next meeting is 21st of February, so about 4 weeks from now. There's been 2 aspects, really, 2 or 3 aspects to this work. One is on data and insight a bit more from a racial perspective lens. And some of it there's been some good work with the policy team within the council and Jean and others. The second bit is actually on sharing good practice. And we've had great example and presentation, for example, from NorthMed on their kind of dashboard around this, which is, I think, is it called 20+5 work that they're doing. And last meeting, we've had also, case studies and presentation from the council and I don't know whether it was CCG or ICB already, but Tammy and others and Christina and Lynette on some of the work we're doing with young Black men from a mental health perspective. So those were quite insightful. Our next meeting in February will have a presentation on the work being done by Whittington Health around from a racial perspective, not least also around some of the good work I think they're doing around workforce development and making sure that is representative and what are some of the things they're trying to do there. And then lastly, obviously, I think it's really important from our perspective that we do, we try and get some kind of tangible outcomes in terms of what we're trying to do. This group is not an oversight group as such, but it's kind of a forum that just brings people together. And we try and there's a lot to do, but how can we prioritize some of the things that can make some practical difference? And that's what this group is ultimately about. I hand over back to Christina or to the chair. Thank you.
Thanks, Jeffrey. Yeah, that was the end of our update. So I'll pass back to you, Chair.
Thanks, Christina. And I really welcome the mention of work on communicating and updating the information and having, because I think it is lacking and it's really important. I also think in my conversations with other councillors, and we have got a lot of new councillors, lots of them are really interested and very supportive of this work. So I think we, outside of this meeting, ought to do a little bit of work around how we engage them, inform them, and encourage them to be part of it as well. That's something we can take aside. And then from that very big picture comment, before I open to others, I was just going to share a comment that came up in the Community Health and Wellbeing Board. And it was as much probably about the next item that's on the agenda as this one, but I thought I'd just raise it with you, Christina, which was around data on minoritised and racialised communities in the borough with a disability. And of course, there we're talking about that intersectional relationship, and I'm not expecting an answer now, but just raising whether or not that's come up. Well, I'm sure it has, but just highlighting, and interested in if you've got any comment, but quite happy also for that to come later, if that makes sense.
Yeah, no, it's a good point, and intersectionality is something, yeah, as you would imagine, we've spoken about intensely from the beginning, making sure that that's weaved throughout the plan. So the fact that equalities monitoring review looked at all the categories, I kind of highlighted race and nationality because of the programme of work. So no kind of big reflections at this point beyond that, but just to say that we very much have in mind making sure that we're capturing the different angles that race also is impacted by.
Thank you. Okay, other questions, comments? Will.
Hi everyone, I'm Will, I'm Director of Public Health in Haringey. For those of you who don't know me, I think everyone does here though. Thank you very much, Christina and Jeffrey, for all the work on this. My comment was around data, and I think me and my team have got a real role to play into this in terms of public health. I think it's really important for the key outcomes we're trying to achieve through this board around health and well-being, and for other outcomes like education, that we have real visibility on the data and see progress. And I don't think we're there yet, but I think we need to embed that in our various programs of work. I think there are opportunities for things like healthy intent. We did quite well during the sophistication for other areas.
Thanks, Will. And actually, in that intersectionality, there's also that question of data, isn't it? So, and we need to do more and do better. But so let's hold that marker. Thank you. Anybody else? Dina.
Yeah, I just wanted to ask you. You mentioned Will's just mentioned educational attainment and so on. There's a massive work going on all the time around attainment and the gap between certain groups and others, between the top, those who attain the best and those who don't. And the data is available. It just needs to be interrogated and to be understood. And I don't really understand what it is you're doing. So if you could tell me what it is you are doing and who you link with and how, or whether you don't link, that would be really interesting if we can do more work, because there is a massive gap in attainment and it's got worse, even though Haringey has done better than most boroughs, for example, in all areas, like from good level of development with the early years up to A levels. Not the percentages are down, but the gap, it conceals the gap between East-West, between African Caribbean, Black, Turkish, Kurdish boys. I think Turkish boys do the worst. So I just want to know what it is you're doing. I just can't sort of visualize from what you said what it is you're doing. So if you and Jeffrey could respond to that.
Yeah, sure. And I can see Jeffrey's got his hand up as well. So maybe if I start and then I can pass over to you, Jeffrey. So through the key bits that we've started on have really gone through the community network as one example. So we have a Turkish and Kurdish community network that was established, as I mentioned, under that health and wellbeing theme, because it came through off the back of a Health Watch report that highlighted some kind of key needs in that community. So through that group, Nick Hewlett has been linked in and attended, I think, quite a few of the meetings actually, where we had a specific focus on encouraging parents to get children into children's centres and make use of various educational offers in the early years that we have. Kerry May also came along from a public health perspective to talk about the anchor approach and how those different community groups and representatives could kind of spread the word, but also do some specific project work on tapping into that. We did share the data that we have locally on both attainment and exclusions for young people from Turkish and Kurdish backgrounds in that forum. And I think it was really appreciated, them being able to just have the data kind of upfront and then think collectively about what we might want to do next on it. So those kind of connections and information sharing and encouragement to take up offers has started, but I feel, yeah, that's absolutely an ongoing piece of work and journey that we'll need to go on to build trust and understand why we're not getting it right for everyone within that specific community. And then I think we've got more work to do across the other community networks. So they've been some of the main routes that we've taken. The Somali community network is also very interested in exclusion rates for their young people. So the link with Nick will be a really important one, and he has been kind of engaged and in attendance at quite a few of those meetings. There was another thing that I was going to say related to the community networks, but it's gone out of my mind. So the other thing that I would mention is the Equal Start project, and Jeffrey might want to say more on this, but that was one of the first projects really that got going through under the umbrella of the coordinating group. So that was based at Lee Valley, and it was a pilot really to see how it went. It, I think, got going during lockdown. So this is while a lot of young people were not able to access to digital tools that they needed to remain properly engaged with education. So both in terms of hardware, not having laptops or enough laptops for the number of children at home, and data. So this project, as a starting point, looked at providing laptops to families, making sure that they had the data they needed. And they saw, I think it was an increase from 13% engagement in homework up to something like 97% once those bits of kit were provided, plus the engagement from the schools, and they did it in quite a targeted way. And then we've kind of built on top of that through that project. So we also had some mentoring support that ran for a number of months within the school, recognizing that there was there's a very large Black population. So talking about issues of race as well as just general well-being, how they feel they can engage, what kind of support they need to do well educationally. And then connected communities was kind of the final layer that came in. So they were providing drop-ins for general support to families around things like any healthcare needs they might have, or financial support, or issues with housing. So we're just in the process of evaluating that project at the moment. And then we can look at how that pilot might be used elsewhere, of course, pending funding. And then that was the thing that I wanted to say before. So in terms of the link, James Page has been the person that has been kind of linking into the coordinating group. He attends on behalf of the education and attainment team, and Sarah Banja had also been involved there. So I will stop there and pass over to Jeffrey.
And actually, Christina, you said everything I was going to say.
Sorry.
But let me just emphasize, really, rather than anything new, because I was going to say those two things. But Councillor Brabson is a great question. The question, I suppose, is the more important one: who are we linking with? Because clearly we don't have the resources to do any practical things ourselves in a meaningful way to solve all of the problems. So it's important that, you know, what we learn, we share with people who are able to do that. So we think this, you know, is a whole family thing, isn't it? We think we need to work with the children in school, target in a targeted way. And also we need to work with the families, because there's also something about the culture there in terms of learning and attainment and all of that stuff. And delivery, the equal project that we've done touched on all 2 or 3 things we're doing there, whereby, you know, where the barrier was digital. So all, you know, they had, I forget now, was it 20 or 30 laptops, I think, that were given out. And you could see the improvement that was there immediately in terms of the participation in homework and so forth. Then also work with a voluntary sector organization who ran some motivation activities with the targeted children who were referred by the school, and also involving some work with their parents. And lastly, bringing in connected communities so that we can signpost these families into different support, because something could be about housing, it could be some other financial pressures which will impact on attainment. So there's a lot of learning there. I know we promised this before, but we think, you know, hopefully by the next meeting now we will have something that we can share. And lastly, yes, I think James Page has done some fantastic stats presentation, didn't he, Christina, to one of our coordinating group. So there's a lot going on there again that we need to kind of highlight that and share that perhaps a bit more. But ultimately, is how we bring all of the key people who can do work together. And it's fair to say there's more that we should be doing. Thank you.
Thanks, Jeffrey and Christina. Before I bring in another question, I just wanted to check as well. And you are making sure you're really well connected with the kind of knowing our communities aspect of the Haringey deal. Yeah, and I can see you nodding. So the answer is yes, good. Because that's obviously a really important part of where we're going in the authority. Okay, then I'll take Sharon's.
Thank you,
Then we
Chair.
might move to the next one.
Yes, thank you, Chair. Gary Passaway, Managing Director for the Haringey Division at Barnet Enfield and Haringey Mental Health Trust. First of all, just to say, I think the training in itself is a really good thing with the Metropolitan Police. So a big shout out to the MIND team and the work involved there. I think if we look at the indices of deprivation, the trust in the Metropolitan Police is one of the lowest in our borough. So that's a big thing. So well done on that, because we need to be doing more of that in terms of how Met can support mental health patients in crisis and presentation. The other point that I just wanted to make is actually, as an evidence base, if we're looking at the draft mental health bill, again, this is part of the programme that we need to be working on. So there's a number of, I won't bore the group with this, but there's a number of recommendations made to government to inform current legislation. At the moment, we are aware that too many of our service users and within our population are detained. And unfortunately, this is also an inequality, a racial inequality as well. So there's much more that needs to be done on that. And I welcome certainly BEH being part of this in terms of a response. And I think this is part of our evidence base, actually, because this is what we need to reduce. Thank you.
Thanks, Gary. And it's really good to have you here. I know the next Health and Wellbeing Board is going to focus on mental health. So I know that we'll come back to some of those things, and it would be good to have a bit more of a conversation about the legislation and changes, etc. I think that'll be really useful.
Absolutely.
as part of that. So thank you, Sharon.
Yeah, thanks for the presentations. My plea is that we, with this exercise, really focused on some deliverables. Obviously, this is quite a wide-ranging, all-embracing strategy that's across a whole, everything the council does virtually in relation to racial equality. And one has seen such strategies many times in the past. But there's nothing wrong with being ambitious, but at the same time, you can talk all day and not actually nail some of the problems. So my plea is, yes, we need data, and that's important. That's forever. We wanted more data, but we do have quite a lot of data about some serious inequalities, particularly in health and social care, which is the focus of this board. And I would hope that some of what we already know about those inequalities, that some targets and some deliverables are reflected in the deliberations that you will have next week. Next week you're going to have them, so that people's time is really focused on, for example, getting down the number of black women that are being diagnosed with ovarian cancer because they're not going for their tests, and breast cancer and all the rest of it. There's some real glaring inequalities that can be lost if we get too wide-ranging, too general about this and trying to get everything perfect before we do anything. So let's focus on some real deliverables, such as the mind training. That's brilliant. That's obvious need. It's been needed for a long time. Let's have some more programs like that really do deliver some results that both we and the community will understand and appreciate.
Thanks, Sharon. I think the point's well made, actually. And Will and Zara know what I think about this as well, which is that there are probably 101 things that we could do, but actually we don't have that resource, and I think that was raised. So we could choose, let's choose to focus on a few things, and there are some pilots. So, and Christina's mentioned the pilot project as well on the early start side. So let's try some things and see results or learn from them one way or another, hopefully both things. And I also think that things like community chest that we've got opening up might open up opportunities for us to be doing things at a grassroots level, perhaps at small scale, which we can then measure and see results both on some of our health outcomes more generally, but obviously very specifically in health and inequalities. I think my feeling is, and I think probably most people on this meeting wouldn't disagree with me, is that most of the things that we need to be doing need to have overlaid over them that health inequalities perspective and take on it. So I think that's a fair point. If we can't do everything, what can we specifically choose some particular, and say, okay, these are the specific things that we're going to focus on.
Report back on this. Could we have a 2 or 3 year program with some clear targets and deliverables?
I think that's a reasonable request, and I'll endeavour to take that forward with the team. Thank you. Mike, got to come in, and then Peter, and then I'm going to probably move us on to the next slide.
Sharon pretty much stole the words out of my mouth. That's pretty much exactly what I was going to say. I mean, you talked about intersectionality, which sort of, all of those various sort of elements of one's identity, but there are also an intersecting matrix of issues and solutions to those issues that, so from mental health to education to training to employment, and all of these things are feeding in. And ultimately, if it ends up just being a talking shop, it's got to be delivered. It's got to have deliverables. And I think there's got to be a clear evaluation strategy. And I echo the point about the MIND project. That sounds amazing. 190 police trained in mental health first aid. That's fantastic. It'd be interesting to know what the evaluation strategy is on that, so we can actually see what the results are going to be. And and I guess on the attainment and the attainment question sort of intersects with representation as well. And you know, we talk about in our own workplace, how we're changing things, just wondering how, you know, you're talking about recruitment and talent, but I'm wondering how much that can feed into the schools element. So actually getting people a little bit like getting young girls into STEM and engineering and those kind of things, starting at an early age to make those changes. And there was just one last observation, which was on the data collection. You had the categories, the ONS categories, and you talked about ethnicity and ethnicity and nationality. But interestingly, used the category, for instance, white other, which would normally be one that is considered race. So it was just an interesting observation in terms of the wording that you used.
Thanks, Mike. Some really good points.
Should I come back on some of those?
Yes,
Is
please.
that okay?
Yes.
Thank you. So yeah, I think in terms of the attainment point and representation in schools, completely agree that there's a connection there. And one of the things that we'd spoken about early on but haven't quite got to kind of nailing an action plan for yet, so we will see if this comes out as one of the kind of key action areas that we'd like to focus on next week, was not just the staff body representation, but kind of decision making and the education community more broadly. So governors, for example, there's a real lack of representation around Black parents, but also other ethnic minority groups, which not only helps to influence children's education, but again, as everyone is describing, these things are kind of so intertwined. It can also be really helpful from a work perspective and people getting into roles through being able to demonstrate, you know, participation on various types of boards and holding different responsibilities. So that was definitely something we wanted to focus on. We've started a little bit of work through the Somali community on trying to encourage more people to get into teaching. So again, Lee Valley actually has a Somali male teacher there, so he came along and gave a presentation on how he got into that role, and yeah, trying to drum up some interest in that career path. So we are taking those bits of work forward. It's just about looking at how we systematize it and also, as you say, are able to demonstrate the impact of those conversations we're having and sessions that we're running. I think in general on the evaluation point, that is what we want to get out of next week. So if we're able to get people to kind of commit to some 1, 2 or 3 key metrics that they would like to influence, and using that similar kind of theory of change model, we can then work back to what action needs to be taken. And then that is the metric that we will be able to put in that kind of 2-year plan and come back and report on. So completely agree on that point. And then the ethnicity point, I think, but I'm going to double check and I'll check before the end of the meeting, that it was ethnicity and nationality that was used, the terminology in our form. But I completely take the point that would usually, you know, white other category would normally indicate race. But I'm going to double check that and come back to you before the end of the meeting, if that's okay.
Thanks. That's brilliant, Christina. And actually, it goes without saying, and I've got a long list of things we might talk about in the future health and wellbeing boards, and workforce one is one, and it came up at the community health and wellbeing board, and it feels like there's quite a big chunk of conversation that we're talking about today that could come back then and would be really useful. I feel like there's a lot we could say around that and around what we'd like to see, especially in generating our own workforce, generating a diverse workforce, and supporting or young people to aspire to different careers, and some of those being within the borough, because areas that we have great need for. I also wanted to just flag, because it occurred to me as you were talking, Christina, that at the Welcome Advisory Board, we were talking about doing an audit of impact on of council services on migrants and refugees, and actually it feels like quite a lot. There's quite a good fit with some of those different theme areas. So let's just, outside again of this meeting, just make that connection between those. Yeah, and we might not have to reinvent, and we might be able to take that to for those that don't know, the Wellbeing Advisory Board meets regularly and has our partners who work with our refugee and migrant populations on it. So, and I know that they know about this programme and are informed and connect very, in some cases, strongly connected, but just connecting that bit too around the audit and our work, and that might be helpful on both sides. Okay, thank you. Oh, Peter wanted to come in, didn't you, Peter?
Yeah, I'm just sort of trying to think to myself where the conduit exists between your learning and crossing over into healthcare, especially primary care. You see, it's very interesting. I was just thinking what Zena said about, you know, the Kurdish population, the one who struggle the most. And I remember, Will, if you remember when we were trying to improve the vaccine uptake in East Haringey, it was fascinating when we got the data, because there was marked distinctions between each minority group. It wasn't just the same. There was quite a marked distinction. We never had time during the pandemic to be able to reflect on that and really to think about it and why that is. And I think in primary care, I think there is a terrible tendency for primary care to deliver healthcare in a sort of uniform way to whoever comes and asks for it. And I think if we are going to address health inequalities, we've really got to start tailoring primary care for the different ethnic minorities. And I certainly know that trying to practice transcultural healthcare is quite complicated, you know, because different groups come with different expectations, different past experience of healthcare from wherever they might have come from. So I think if there was a possibility of passing over some broad learning points to pass into primary care, it'd be really helpful.
Thanks, Peter. That's a really useful point and connects with many of the other things we've talked about before in this group. And actually, we've got Cassie on the call, and I feel like it's something that GP Federation we could pick up as a conversation. Cassie and I met last week and had a really useful conversation around all sorts of different things. And I feel like it touches upon some of it. We talked about young people's health. We also talked about primary care also being that touch point, sometimes the only touch point, and then therefore how important those moments are. And you're quite right, if those moments are difficult, and we heard about that in the feedback we had through COVID, was people had difficult, problematic interactions, and that really was one of their only system interactions, and it was negative, and that really killed any possibility of a future relationship, connection, and trust. So really, I think there's a lot there. Shall we take that away and we'll pick that up outside with Cassie, Christina, and the team, please?
Thank you. That would be really helpful. Thanks.
Thanks very much. Okay, so I'm going to move us on from this item. Thanks very much. We've got some clear asks, and I just want to thank the team as well. I know it's a lot, and you know that there's a great burden, which is a system burden and a society burden, and we're asking you to take some of that on and help us tackle it. I know that's not a small task, so thank you. Okay, this is the point where I'm going to vary the agenda. Apologies, everyone, but just making sure that we take item 11 while that's still here. So I think we've got Paul on, and you're going to take us through this item, aren't you? And apologies to others who I know are expected to go next. So Priyal, I'm sorry, but we'll come to you next. Okay, Paul.
Hi everybody, apologies for this. I've got a short slide pack, which is actually in the notes of the paper. So I'm going to put those up if you're okay with it, and just quickly run through that. So just bear with me. Oh dear, where it's gone. I'll just apologies. I just had it open and I've closed it down again. That wasn't very bright, was it? Yeah, I've got it open now. Just bear with me. People see that? Yeah, we're all right. So yeah, so this is a short agenda item, I hope, about kind of the discharge scheme for 22-23 for the Better Care Fund plan. So just to give some context to this, this was originally announced in the autumn budget. The government announced an additional £500 million between ICBs and local authorities as part of, as it turned out, the Better Care Fund plan. And there's an added element to the Better Care Fund plan, predominantly to support timely and safe discharge from hospital into the community and to help people clearly recover their health and well-being outside of the hospital, clearly ideally at home. So this is building on the investment we already provide within the Better Care Fund plan anyway. And so the idea is it's an additionality to the investments that we've got. So clearly there was then a gap between the announcement and the release of the guidance, which was in early December, for obvious reasons. And when we saw the kind of guidance, it was relatively complicated. But what it boiled down to for Haringey, what was finally kind of agreed was there was a 2.2 million investment to fund adult social care, mental health and community schemes. Just under £1 million of that was directly to the council, and then the other 1.25 million, more or less, was from kind of NCL ICB allocation. So we agreed within North Central London a set of kind of principles governing how we were going to utilise the scheme, which I'm going to come on to in a moment, and then had to make a submission and start using the scheme from around about the 16th of December. What I'd like to present today very quickly is the schedule of those schemes and say a little bit about them. They're still being rolled out because obviously, saying you're going to do something on the 16th of December, you need a little bit of time to kind of organise some staffing arrangements and so forth as well. So some of them are still being kind of rolled out as we speak. And then there's one or two other things I wanted to kind of touch on for 23-24. So these were the kind of the principles that we agreed around it. The money has to be treated as non-recurrent with schemes ending in March 23. I'm not going to go through each of these kind of principles because, they are kind of the ones that we used. And the level of scrutiny on this is that our first return about the funding we were utilising was for, I think, the 6th of January. And then thereafter, we're reporting on a fortnightly basis. So we had to agree some metrics for the health and wellbeing area and the planned ambitions for the scheme as well. But what you'll be interested in is actually the details of the scheme, which is in the slides. So I've talked through, the different levels of investment. So there's substantial investment in a number of areas, and I'll talk a little bit more about the kind of the individual schemes on the next slide. But basically, they were in a significant investment in supporting people to get home more quickly and to support them to recover at home through reablement. There was also some investment in actually addressing some of the issues that people face who've got housing issues, not just people who are homeless or risk of homelessness, but also people who have got problematic or challenging housing environments, such as needing a deep clean and so forth as well. And we've seen a rise in the number of people that need that sort of solution. We also wanted to invest in, we shouldn't forget about kind of mental health investment, both for people that are in the acute, but also people who are in acute, non-acute mental health hospitals as well. So the funding is equally for those groups as well. And so there is a significant investment in that arena, and that includes people with dementia. There's also a funding contribution for the population that maybe they haven't got kind of severe mental health issues, and in fact, actually, they've got more physical health issues, but still have got relatively complex cases, and they need to go somewhere else in the community, into the community, but not necessarily their homes to recover. So there is a item number 4 kind of outlines that kind of issue. Item number 5 in that list is an investment in NHS rehab beds, which are people who need rehabilitation before they can kind of return home in a bedded unit. So there's been an investment recently in kind of the Magnolia unit within kind of our local hospital system. And finally, item 6 is a investment in some of the kind of enablers to support some of the arranging of care packages and the kind of the arrangement of placements within care homes, for example. So in total, that comes to the £2.2 million. So both the ICB and the council and its partners have kind of largely agreed the schedule of investment. So just very briefly, there are 3 main areas of kind of investment in there. I've talked already about recovery at home, but actually that's formally reablement within the council structures, which is short-term help to get people to recover their health and ability to undertake daily living tasks, and sometimes provide a short-term package of home care as well. And that's prior to any longer-term assessment of health or social care needs. The idea being clearly helping people recover first before you do an assessment of their needs. The second element I've already mentioned, which is actually we've got a number of flats which are being kind of reutilised and repurposed within Stokely Court to support people who've got those housing issues. So again, that's a place for those individuals to recover, to work through their health and housing and social care needs, decide on the next steps for them, and to undertake any assessment of health, social care or housing issues. The final sort of category is short-term placements in NHS rehab or care home beds, whether that's, as I said, acute or non-acute hospitals. And again, that's to help people recover their health and functional abilities in daily living. Decide before you kind of place any individual in then long-term kind of care home, or alternatively within hopefully going home, because a lot of those individuals do return home. It's an opportunity to kind of get them to recover. So what we've got is just the next steps for this. We're asking the Health and Wellbeing boards to endorse the investment schedule because it's part of the Better Care Fund plan. An announcement from NHS England at the same time in the autumn statement around this funding continuing into 23-24. We haven't really got, other than the outline investment level, we haven't really got any of the details of whether it'll be more or less the same as it is now or different. So that's something that we need to work through. And then the final kind of couple of thoughts on this are, in the middle of all of this, we also had an announcement from the government about a further £200 million over and above the £500 million that we've already committed this financial year to support discharge of patients who need step down into care homes outside of the BCF plan. So that needs to be spent by March 23, which, is challenging given that it's kind of the, early January now, and we've only just got the details of that kind of that scheme. But we will need to come back and talk through what that means. So, we're also looking at that as being the discharge funding, rather, as being part of the investment into the BCF plan in 23-24 as well. So there'll be some further information comes through and decisions for the Health and Wellbeing Board as part of the preparation for the Better Care Fund plan for next year as well. So I'll just pause there and see if there are any questions.
Thanks, Paul. So I just wanted to say a few things. One is that, and just so that the Health and Wellbeing Board members are aware, that Paul and Will and I did have a conversation in December around this, and obviously we weren't able, given the timings, to bring it to anyone. I have to say, I'll say the things that Paul can't say, which is that it's extremely challenging, and that the government, I think, do consistently put local authorities and their partners in a really difficult position. It coming so late, it being so tight. The letter came through with all these deadlines around when the feedback was going. We also know we were already working really hard on hospital discharge. We had that presentation around some of those issues at the previous Health and Wellbeing Board. So I think it's extremely challenging. It's extremely unfair, and it doesn't, I don't think, match up to where we'd like to be in terms of actually knowing about how we're being funded. And it's a feature, in my view, of the dysfunction inherently in the system nationally. I think it falls on me to say that where others can't, but I think that's the case. So I would thank people as well, because I know it's really hard in the midst of the other things that everyone's dealing with, in just trying to deal and come together on this. So I think it's important to acknowledge that, and it's important for me to say those things. Having said that, and there are just a couple of things I wanted to just add on a more, I suppose, not so much parochial level, but just some of the things that I'm hearing about from residents, and I know Vicky's not here, so they might float in the ether, but Sarah might be to pick up, or we can pick it up. One was some concern about we're relying on discharge to assess, and some concern that if that doesn't happen in a timely manner, for all the reasons that we would imagine, that is causing some issues. So that's some of the feedback that I've had personally, and also my sort of particular bugbear, which is around access to good occupational therapy, good physiotherapy, which is really important in that reablement process. And we know it's not always as timely as it could be, especially if residents come out on the weekend or they arrive on a Friday. I think it's not acceptable for people to wait till Monday. It's actually you've lost 2 days of doing something, and that's really important. So just a couple of things that are much more less on the strategic, but more on the more practical. And then I'll open it up, and then we can come back and we can comment on those and others. Mike, you did indicate.
Yeah, well, I'm going to say what I said before. You've actually taken the words out of my mouth, and that's how I was going to begin, is to say that I find this incredibly infuriating and frustrating. You know, if I do, practitioners and officers must be finding it, you know, trebly so, if not more. Just all of these little pots, which are time, you know, got these time locks on them. You've got to spend the money by this amount, and it's not ever enough money. I mean, I looked at, you know, 500 million, and I thought, that doesn't sound like very much. And then when I saw Haringey's allocation of 2.2 split between the NCL and the authority, it was just like, really, what are you going to do with this? Now, well, it was quite incredible to see what you have got organised, quite a comprehensive sort of approach. And but the reality is, well, I guess that's my question, is the reality is how much can really be delivered on that, where, you know, in terms of, so obviously you've got that, and hopefully there'll be the next round of funding to help complete it. But I guess rather than say, can you deliver in this amount in this funding window, which is, where would it take you in terms of the full, you know, in order to get the house in order, so that actually we're looking at those return home solutions. Where would this take us percentage wise towards that, this year's allocation? Are we talking less than 5%, 10% there, less than 2%, 50%?
Good question, Mike. And it's a hard one to answer, I suspect.
I mean, I think that it's not possible to give a kind of quantification of where would this get us to, but I guess to contextualize it, if we put all this, that we've put the highest proportion into our reablement service, and the requirement from government is very much to demonstrate additionality. It's really difficult to demonstrate additionality because we have a gap, an absolute sort of funding gap. If we were to put all of this again, the same amount again, into the reablement service for next financial year, it still would not help. We would still not achieve financial balance. So for next year, we will need to be working really hard on what is our model of sustainably providing a really strong service that allows us to discharge people in order to assess them in the place that they're comfortable. So again, you know, just to sort of contextualize it, it is not adequate. I think Vicky, if she was here, would say it is not adequate for us to continue, even if we've got the same again, to continue to run the service as we're currently running it, and we need to look at that service really, really carefully. And that's what we're doing alongside partners, because the health rehab is also really important, and so we're looking at it, and as you say, it's really challenging because we can't. What you need is sustainable funding in order to employ the staff who are the ones who deliver the services. And what's most challenging about short term is that it doesn't allow us to really to make moves to increase our establishment or to make those changes for the long term.
Can I just make one little comment?
Yeah, that's fine.
It just seems that it's the cart before the horse completely. Like, so what you just said is essentially they've come up with a budget and said, right, see what you can deliver on this, rather than going, what do you need to deliver on this for the next 5 years, right? And we will then work out what of that we can fund for you. And frankly, it should be all of it, but but it should be that way around rather than the way it is here.
Yes, and I'd add a little dimension, which Rachel can correct me on if she doesn't think I'm accurate, which is your summary is right, but also, and you need to spend it in this really short time, and you need to come up with new ideas, new things to do, rather than actually we've already got some really good things in place that need kind of boosting. Before we move on, is there anyone who wants to make a comment on my comments about discharge to assess and OT, or do we think that would be?
Paul's got his hand up.
Oh, Paul.
Yeah.
Yeah, I mean, actually, I mean, the kind of the issue that you've described, Councillor Desneves, was raised today at the Age Well board. So I've agreed that we'll take it up formally with kind of some of our hospital partners and as well. So, I mean, I just wanted to come back to the other issue about the demand thing. So we're doing some work. We're probably ahead of the game in North Central London, if I say so, about understanding what the impact of kind of the pandemic's been on particularly the frail and elderly population, which are often the groups that most use kind of reablement recovery services, if you like. So it looks to me like there's a strong case to say that the number of people due to the pandemic and the legacy of COVID, and it isn't just people who've got COVID, this is people who've isolated and, their health has got worse as a result of that, is probably increased by about 20% in terms of moderate severe frailty. So that's kind of not necessarily confirmed, but nobody I've put that case to seems to be disagreeing with that percentage rise at the moment. And we're starting to see some evidence around some of those things. So we've definitely seen an increase. So to answer your question, as we're trying to do that work to say this is the quantum of kind of needs that are coming through, and we're doing some more detailed analysis on it. But I mean, we've got this money, we have to use it. Basically, is the kind of the message behind some of this for the day for 22, 23. But I'll be very happy to share some of that intelligence with the Health and Wellbeing Board, so you could see the kind of demand side of the equation at some point.
Thanks, Paul. That might be good in writing just afterwards to share along, if that's possible, when you in your spare time, which I know you don't have a lot of. But thank you, Tina.
It's all right.
Yeah.
I think this is. I know there are lots of questions in my mind about this. I think in terms of the politics of it, I don't think we would expect anything else from a government that is only interested in the headline and NHS waiting lists and all the problems of bed blockers. They've just put money there because it's a headline. I think that seems to me. However, we've got some money and we have to use it. And if we don't use it, we'll lose it. So we are between a rock and hard place. I think it just is the pragmatic situation. And if we use it, we may well get more because we've used it. And my view is that the government, again, I'll say things that I think, no, Lucia and I and Mike are in a position we can. I think as the clock ticks in 2023, I think we see more money. My guess is more money will possibly appear. That's a hunch, only because of the pragmatic thing of getting near an election, really. Having said that, I'm really concerned about the detail of this, which I think you sort of touched on, Rachel, very diplomatically, because we either run it ourselves, either we run it with staff teams that we have, as it were, we being the Integrated Care Board, the partners and so on, or it's contracted out. I suppose those are the two options. And if it's contracted out or commissioned, I'm really concerned about how that is managed and what the accountability is and how the quality of service that is delivered and how we know that and how we monitor that. Because, different people turn up every day or times, all those sorts of things that can happen in a really complicated landscape here. So it's really a question about how this is all being managed and operationalized in order to get the best outcomes, and to ensure some quality standards. I think it's really, really difficult. I wouldn't want to be running it. I mean, it'd be very difficult, and I really do wonder have we got strong enough systems? I'm really just asking those questions, not to be difficult. I just think that the government's thrown some money at it, and now we've got to do it. And have we got robust systems to do it? And are we planning for April, when clearly more money will be appearing, to have robust systems, whether they're in-house or externally commissioned? That's my point, really.
To try and come back.
If you can, right.
I think that our biggest challenge today, we had a finite pot. You want to spend it, and actually it was the attribution between our different schemes as much as anything, because there are too many things that we would want to spend money on. So we've been talking on many occasions about patients coming out of acute mental health inpatient stays, smaller in volume but high in complexity in relation to the volume of patients that come out of our acute health trusts, very high in both complexity and high in volume, and how do you attribute the funding between? And so that getting that right is really difficult. There is no right answer to it. I don't think that we, through this funding, have ended up doing a lot more commissioning of external providers for either care packages or step down accommodation. We've actually, by and large, it's been an extension of services that we already have in place. So I don't think, looking to sort of partners around the room, but I don't think in particular sort of, it's not placed an additional burden on us in terms of quality review or control. I think that the risk we have is that when it comes to some of these pots of funding, so this we have been able to spend. It has been a lot of work. It's still a lot of work. We've still not, but when it comes to things like the additional funding that's been announced, that additional 200, I think it was 200 million, because that needs to be spent on, it needs to be spent on people within a care home setting, so it needs to be bedded care, and it needs to come to an end on the 31st of March. That is very difficult. That is very difficult. So we are in danger of finding it too difficult to spend funding. Not to say we won't make every effort, of course we will, and that work is ongoing, but people's packages of care don't just finish on the 31st of March. So that's,
and in fact, we have to be really careful about how we do that, because we could be putting people at risk. If we make a plan that's quite looks to me like quite intensive care, and then we say it's going to drop off, you know, into something else, that would be not responsible of us. Yeah.
But I think the main focus for us is actually in the other part of your question, which is about planning from April. So to get ourselves into a position where we have where our services are not reliant on external sort of additional pots of funding that you can't depend on. So how we run our reablement service in that way that we can offer a good and consistent service to all those who need it, really reliably. So we've got quite a lot of work that is happening on doing that planning, but if there is additional funding. So I think being able to have a shared pot of funding that we can use, it is that discharge to assess. It's to enable people to come out of hospital, and I am talking about from mental health hospital as well as from acute trusts, that then we have some time in which we can do the assessments, and then we can assign the funding responsibility. And actually we had that through COVID, and I think we really saw a positive impact on that, where we had a discharge fund that was available, it made the process just much smoother for people. So I think for Haringey, that's the sort of consideration that we've got now, is if we had additional funding, could we use it for that sort of funding without prejudice type of arrangement that then and it does still, you did talk about sort of the assessments within 4 weeks. It does still mean that we have to do that, but that is a much better ask, and we already expect ourselves to do that. And it's really important that we have those conversations about people's needs and attribution of funding after people are out of an acute setting. So I think that would be our priority.
That makes perfect sense, and I don't want to browbeat you on it because it sounds like some other people probably already have been at Ageing Well Board, but I do feel that, but it's that nexus of getting that right though, isn't it? Because there's a lot of concern, because for any of us, we want, when we leave the hospital, to know and have surety and understanding on what's going to happen. When you're more vulnerable, it's much harder, as you all know, to have surety generally, and your own personal circumstances might give you less if you're alone or living with a vulnerable family member, whatever it is. And it's also about the timeliness and the confidence, and also making sure that you're not adrift for any time, because that time is really important, isn't it? When you come from hospital and you're in that early recovery phase of whatever it is that you've experienced, is really key. So I think that's where the concern is, but I'm not going to say any more because I know we'll talk more about that. Sarah, did you want to come in on that? And then
Well, I suppose
Gary.
just to add that all of this is a very much a work in progress and a priority for the service and department. So we're meeting again on Friday as a group of senior leaders to discuss, and then to start thinking about putting those future plans in place. I suppose it's just assurance to the board that it's sort of high priority and on the agenda, and that we've got a series of discussions programmed to come up with the options.
And then you'll come back to see me as well, yeah, in the interim before we're reporting back to
Absolutely.
Health and Wellbeing Board. And actually, we could also think that if this is something the board is quite concerned about, we could think about whether or not we have written something to the board in between now and the next meeting, just about just covering off how we're delivering, and particularly maybe about that focus on prep to April. I don't want to create more work, but I'm sure there'll be some documentation that you can kind of rework work that we could share with the board. Gary, I mean,
Thank you, Chair. Unfortunately, just to pick up on your point as well about the timing and how these funds come. Unfortunately, there's nothing new in that, in the sense of quite often it can be even winter funds. It can be very lastminute.com. The trick is, I've always thought it was a bit of a trick from the centre, but it's about mobilising it. They used to always say, we'll have something ready on the shelf. Yeah, we can have an idea and a scheme, but it's always about mobilising it and getting it set up and spending it. And that's an art form in itself. So unfortunately, the actual funding and the timelines is nothing new. I think the key point on something like this actually is it needs to demonstrate value. It needs to demonstrate what the impact is. And look, I've had a chat with Rachel even this morning, and I've fed back to Paul. At the moment, with my mental health hat on, this is having limited impact at the moment. So I welcome the comments that, when you mentioned about the discharge to assess type model, because that's what we can work towards. Because at the moment, quite often there will be patients, the new terminology, clinically ready for discharge. They can leave the ward. They don't have to be on a ward. So if it is an assessment or an X, Y, and Z that can take place elsewhere, then we should be supporting doing that. If we can do it in the acute, we can do it in mental health. And we did have the pilot. So I'd welcome us taking that forward again, because if we can demonstrate value, it will support the case for recurrent funding. Yeah. So that's why it's really important that we do pick that up. Thank you.
And you won't get any argument from me, Gary. I mean, you and I haven't been in as many spaces at the same time. But had we been, that one of my biggest concerns is mental health, and that's support onward in the community, because what we're seeing is cycles of people being in difficulty, and actually it's a great strain on them as individuals, their networks, their neighbours, their neighbourhood, and more broadly. So I think, and quite often we're feeling the local authority. I think last time we were in a space together, we talked about those things actually. Yeah. Then it kind of falling here at the local authority, we're like, oh, this is a very complex picture now, this person. So making sure someone comes out and has the right support as soon as possible Great that they come out so that there's space for someone else to go in, but great that there's the right kind of support. And actually, I think I've raised this directly with the ICB, at least on one occasion, if not more, just having the right things in place so that we have confidence that they are kind of being held, that their medication that's its side of it is under control, if that's in the mix, what have you. So absolutely, yes, definitely an area we need to focus on. And I think every councillor will support that, in the sense that every councillor is seeing some really serious case work coming across their desk around mental health in the community.
Absolutely the most difficult area in case is mental health. The most difficult.
And actually, when we had our, so I'm digressing for 2 seconds, when we had our briefing on safeguarding, Vicky and Beverly on here, 4 councillors, actually it became quite a discussion about that, because we had lots of councillors, very experienced, some quite new, and everyone talking about that and about challenges with supporting people and supporting their neighbours and their family and their communities around some of the issues that they're experiencing. So very good to highlight it. So thank you. I'm conscious of time, and we've always got a packed agenda. So unless, well, I can see Jeffrey wants to come in. I'll bring you in last point, Jeffrey, and then we're going to move on.
Thank you, Chair. Very briefly, I'm a bit outside of this discussion in the loop. So, but some of the points I was going to make was Guy has actually made them around some of the mobilization. I want to be really positive. You know, I think it's a good problem to have, isn't it? Ultimately, because there's some money and some resources, and it's a question, I suppose, to what extent we have positioned or prepared, to Gary's point again. So I know, you know, and I don't know to what extent also we are having discussions with, let's call them providers of this pathway, if you like. You know, Sarah talked about, you know, leadership meetings and so forth. To what extent are we asking people, what more could you do? And I think to demonstrate then the impact that is required there. So not sure what that process looks like. And then lastly, I think the challenge is, to Rachel's point, is around how do we demonstrate, you know, at what point do we need to demonstrate the impact in 2 months' time, or is that a bit later on? Because I think the span and the other bit could be done. Suppose the problem, lastly, is there some sort of mobilization that's required, or are we kind of building and extending and flexing what we currently have? So those were some of the points I wanted to make. Thank you, Chair.
Thanks, Jeffrey. And before we answer your question, I just want, because Councillor Carter's packed his bag, so I just want to confirm why he's still here, that we are, of course, supporting this item and supporting the work, and recognising the challenge, and of course always asking for more and more, because what else would we do? But so whilst you're here, thank you, thanks. Okay, now we'll just want to respond to some Jeffrey. Part of me feels, Sarah, there's something there about what we're asking of our voluntary sector. I feel that's what kind of in a way Jeffrey's asking, and you know, and how we're mobilising them in this issue. And then maybe Rachel wants to.
I think we can pick that up as a discussion point in our meeting on that we have on Friday, and we'll feedback to Jeffrey. It's one that I need to take back to Vicky, really, in terms of oversight of that process. So we'll come back to you, Jeffrey.
Yeah, I think it is something for us to explore going forwards, particularly for those we already have services that reach into the hospital, take people home, support and resettle. So we're very kind of mindful of that as being a really important part of our offer. So it's not ignored. This is largely building additional capacity onto services that we've already got, not exclusively. Some of it was about standing up units of accommodation that were not ready. So we're in process with that, never as quickly as we would like them to be ready, but that's in process. Most of the rest of it, this is about additional capacity to existing services.
Thank you. And if we have time later and Vicky does manage to make it, I might give her a moment to talk on this topic because I know she would have wanted to, if the chair hadn't varied the agenda. So thanks, Paul, and all power to you all on this piece of work. And we look forward to hearing more and on, and maybe having something in writing that I can share with the board. But
Thank you, Chair. Take care, everybody.
Thanks, Paul. So now we're on to item 9. Apologies, Priya, I made you wait. We've got Jill too and Will. I'm not sure which one of you is going to start.
It's me, Councillor Desnevson. I suggest we try and go through the pack quickly so we can have more time.
Yes, please. Assume we've read it.
Yes. So I just wanted to help, and I wanted to frame it in. At the start of the meeting, I talked about our work on health inequalities.
I'm sorry to break in, but we can't really hear Will.
I can hear Will. But obviously
is
he
that
can't.
better? Is that better?
Yeah.
Yeah. I'll speak really loud. So I want to frame this in 2 ways. So we talked about health inequalities in our first item from the perspective of minoritized communities, and we also talked about disabled people as well. So clearly our approach as a health and wellbeing board is to improve the health and wellbeing of all residents and tackle inequalities. So when we talk about inclusion health in this paper, we're talking about 5 specific groups. This is a kind of grouping of cohorts of people who have really significantly poorer outcomes than would be expected, and we want to improve those outcomes. And there's a kind of traditional grouping around here, but you could, of course, include the other discussion more broadly around inclusion health. So that's just framing that. And the other thing I wanted to frame is in terms of partnership working. So we're presenting here in North Central London needs assessment, and we've got colleagues from the NHS who are going to talk about that work. Looking at this systematically, we just had the item just before this showed how stretched the health and care system is, and it's really important that we keep healthcare for people who are really struggling high on the agenda, have a systematic way of looking at the needs of those groups of people. We are working closely with that team in Haringey, and we're doing some really good work in some of these areas. We have got gaps in other areas. So Jill is also going to talk about some of the work that we're doing locally. So I'm going to hand over, I think, to Priyal and Sarah now, just to talk about the context before we go back to the local with Jill.
It's worth out loud naming those 5 groups so that we've said that. Is that useful?
Yep. So people experiencing homelessness. We've got vulnerable migrants here, and that's a broad group that includes refugees and asylum seekers, which we're doing lots of work on in Haringey, Gypsy, Roma and traveller communities, sex workers and people with a history of imprisonment.
Okay, Priya, go ahead.
Hi, good afternoon, everyone. I'm Priyal Shah, Programme Manager at the Communities team at NHS NCL Integrated Care Board. And I'm here with Sarah, who is also, I don't know, Sarah, if you want to introduce yourself now.
Yeah, thank you. I'm Sarah D'Souza. I'm Director of Communities. Priyal is part of our team, and our role is about making real the Integrated Care Board's commitment to health inequalities. And I also, as part of that, have a lead for homelessness for the ICB.
Thank you. So over the next few minutes, we will just give you a very brief overview of the work we've been doing on inclusion health over the last few months. And this is in Haringey as well as across North Central London. And as Will mentioned, there are some groups of people who fall between services and who may not be accounted for in health records, and they have very poor health outcomes as a result. And these are the inclusion health groups. And when we looked across the 5 boroughs, we noted that we have varied and very limited information on inclusion health groups in terms of their demography, their health needs, their outcomes, as well as their experience of using health services. So we set up the inclusion health needs assessment, working in partnership with the directors of public health across the 5 boroughs, as well as other stakeholders. Will mentioned the scope, which includes people experiencing homelessness, vulnerable migrants, the Gypsy Roma traveller communities, sex workers, and people with a history of imprisonment. And we developed the inclusion health needs assessment in 2 phases. So phase 1, which is now complete, and I can tell you more about it, is the rapid evidence review, where we collated evidence already available either locally, regionally, or nationally on these inclusion health groups, in terms of what we know about the demography, the health needs, barriers to services, any service provision we have, and also gaps in service provision. Phase 2, which is ongoing and expected to complete next month, is a piece of work on extensive engagement. It includes interviews with people with lived experience from these groups. It includes interviews with senior stakeholders to understand challenges and priorities at strategic level, as well as a staff survey to understand the frontline experience of delivering care to people in inclusion groups. And the aim is to bring all this information and findings together so that we can use this information for future planning and commissioning health services. So there is a whole load of detail in the slides about the different inclusion health groups, and I refer you to the slides for more information. But I just wanted to pick out a few themes that really came out and that make us think about how we're delivering health services. So firstly, it's information. So we have the most information and evidence about people experiencing homelessness and vulnerable migrants, whereas we have very limited information around people from the Gypsy Roma traveller communities or sex workers. Secondly, we've noted that there are some common drivers that push people into social exclusion, and that's across the inclusion health groups. And this includes domestic violence, substance misuse, or mental health problems. Thirdly, we noted some overlaps between groups. So we know that people experiencing homelessness may often have a history of imprisonment or may have used substances. But we also noted other overlaps. For example, vulnerable migrants comprise a significant proportion of sex workers. We know about diversity within groups. For example, we know the Gypsy Roma traveller community is quite a diverse community with Romani gypsies, Irish travellers and travelling show people, and also different living circumstances, whether they live in caravans or bricks and mortar. And all that affects how we deliver health services to these communities. We know the diversity within our vulnerable migrant groups with different nationalities and ethnicities. Coming back to health needs of these populations, in some ways there are similar health needs in terms of mental health needs, untreated long-term conditions, as well as history of substance misuse. But often these groups also have their specific health needs in terms of maternity care or even sexual health care for sex workers. Coming to service delivery, we looked at barriers to services, and many of them have similar barriers. So first is stigma, fear of stigma and discrimination when accessing services, the lack of ID or a proof of address to access services. Some of them often don't know about services they're entitled to or are not able to navigate the health services to actually access them. When they experience health services, there is also a fear of trauma from past experiences, which again impacts on whether they do reach out for care or not. And finally, we know that sex workers and vulnerable migrants often have additional fears of prosecution or being reported to authorities. So all these barriers are similar, but they also have some differences between the different groups. Coming finally to service provision. In Haringey and across North Central London, we have noted that we have considerable health provision dedicated for people experiencing homelessness, In Haringey, we have the Homeless Health Inclusion Team. We have the Mulberry Junction Centre for providing holistic support for these groups. For vulnerable migrants, we also have considerable health and care support set up, but we don't have the similar health and care support for other inclusion health groups. So this was a very high-level summary of the key findings from the Inclusion Health Needs Assessment. As we mentioned, phase 2 is in progress, and I will now hand over to Sarah to take us on to some discussion and next steps. Sarah and Jill, I should add, sorry.
Hi, thank you very much, Priyal. So I'm just going to talk a little bit, and I'm just checking that people can actually hear me. Yeah, good. I'm just going to talk a little bit about what next, really. So as you've heard from Priyal, the final phases of this work will complete end of January, early February, and the work and the understanding of the needs and the issues faced by these populations will really be deepened, I think, very significantly by that work, particularly the views of people with lived experience. But this will only make a difference if we act together in partnership around those needs. And for me, work on inclusion health is really a litmus test for our partnerships and their effectiveness, both at borough and system level. And I think there's a real opportunity here with the emerging integrated care system and the responsibilities that it has around inclusion health to really prioritise the needs of these vulnerable and marginalised groups. So we will be coming together once we have completed the needs assessment in partnership to develop recommendations with stakeholders, and the aim will be to take that through our governance around the integrated care system, through the integrated care partnership and through the population health and inequalities committee, but also to work through local governance, through health and wellbeing boards, and with our commissioners, our joint commissioners, to start to have conversations about how we work, particularly around those areas where we know there are significant gaps. Now, the aim of the NCL-wide work, just to be clear, is to facilitate and enable and add value to what's happening at borough level. It's not to replace it or cut across it. And to give you some examples of the partnership work that we've done to date, particularly around homelessness, which is, I think, has significantly added value to what we're able to do together. So one of the things we've been able to do is to do some consistent training across hospital sites. We've been able to share good practice. Some of the experience that's come out of the Haringey homeless and inclusion team has been really powerful in terms of supporting some of the other boroughs in their thinking around multidisciplinary team working. We've also been able to work together to pull down funding for things such as out of hospital care for people experiencing homelessness, and also making the case locally around how we deploy investment to meet these needs. So it will really be a sort of case of the NCL-wide work very much going hand in hand with the work that's happening at a Haringey borough level. So I hope this is helping to inform thinking and builds on the work that you're doing in Haringey. Would really value your views on phase 1 and also where we can add value ongoing together to borough work. And I'm just going to hand over to Jill because I think she's going to put this very much in the context of the work that you are doing in Haringey now.
Thank you, Sarah and Priyal. So I guess just for the benefit of people in the room that will be aware of different work in this space but might not have connected it to the kind of inclusion health agenda, some of the things that Priyal and Sarah have mentioned. So for example, the homelessness health inclusion team is a really obvious part of this work, but some of the less obvious aspects of this work might include some of the projects being funded through the Inequalities Fund, for example, that are specifically working with groups of people affected by racism and by migration. Similarly, the work that we're doing in the borough around violence against women and girls is a really critical way that we engage with sex work, and the intersection there with homelessness is also really important. And there's some more work in the coming year that's coming forward around sex work in particular, looking at how we understand how this group of people are particularly affected by things like the cost of living crisis. What does that do to their access to services? What does it mean about their safety? And of course, that all really connects with health. So there's a lot going on there. Many of you have been involved in work around safe surgeries in the past. You will have heard of the Find and Treat teams, for example, supporting various people around TB. We've had Doctors of the World working with us in the borough for several years with their bus in various ways. And so there's lots and lots of different activity that happens already in Haringey in the inclusion health agenda. And I think we're in a really fortunate place that we work really collaboratively with the ICS on this. Actually, to the extent that I'm speaking at a webinar series on Friday about the work that we've done to a kind of national programme supporting ICS leaders to understand inclusion health more. So we're doing good things, and that's really, really positive. There's much more to do. And I think one of the things that I know many of you here will be interested in is how we support the Gypsy Roma traveller community more effectively. And I've got a small amount of money to recreate a role that used to exist in the council supporting that community. Unfortunately, the previous post holders passed away several years ago, and the role wasn't recruited into. So we're really happy to be bringing that role online this year, again, with the aim of understanding more about that community. And I think we can't understate that the lack of information we have means we're reliant often on very old data and very small numbers of anecdotes. So I think we really need a better understanding of how we're supporting this community in particular, but others as well. So there's lots going on. It's really positive, a really positive area of work. It does also, as Sarah mentioned, I think, or Priya, it does generate opportunities for income as well. So it's also opportunity for innovation and to do things differently and to test new ways of working, which I know that many of you are doing already. And it's really exciting. So I think that's probably more than enough from me to close. So any questions, very welcome.
Thanks, Jill. That's really helpful, actually, because when I was listening and when I've been thinking about this, I'd written down holistic approach. And what I was thinking about was that joined upness, and also, and you're quite right, actually. I feel like we have got a lot of work in place on Mulberry Junction and on migrant support, and I have quite a lot of confidence in that area of work. And there's plenty more to do, but we've done a lot. And I think probably every single councillor would agree with me that the Gypsy, Roma and traveller community needs much more attention, and I think that does require a really holistic approach. We have a few councillors who I know are particularly grasping that mantle and leading with that baton. I think that's really important. But the conversations I've had with them have really indicated about that real holistic approach and that real deep understanding of the community. And then that's when we can achieve things on health and well-being and on a whole load of other fronts too. But we can't work in this separate. We have to see those things as integral. And I think that's probably really common to a lot of the conversations we're having with what some people term our hard to reach communities. I don't really think of it. I just think we haven't really got our heads around the right way to communicate with people. And I think the phase one, identifying trauma, I think that's right. I think that's probably true about all these groups and many of our other residents too. They are carrying trauma of experiences, of interactions with us, of interactions with society, and much beyond. And all of that makes it really important that we have that with quality, deep engagement, and that takes investment time. I also feel it's really important for us to be connected. Glad you mentioned VORG, Jill. That was really important. All our approaches to violence against women and girls. But what's sort of kind of come across my desk a few times lately also is term modern slavery, and I was looking a little bit more at that, and Lynn and I chatted really early doors about that. And again, all these things are really interconnected, because when you have a touch point with someone, and once it becomes a quality moment, at that point you can then maybe address more than one thing. You can talk about health, you can talk about some of those outcomes you're talking about. So for me, it's about that. It's about really deep and what of course I've written down funding. You mentioned funding. For me, it's about how we can fund things that create lasting quality relationships, but are there with people, recognise that it's not tomorrow that they're going to get, that they're suddenly going to be, say, have all the immunisations, have all the testing. That it's not like that, but actually it's about spending time with people and then having that deep relationship, which will then lead us to the better health outcomes we want to see, and actually a hell of a lot of other things probably while we're there. I'm going to take online first because I haven't done that yet today. I'm going to take Cassie, because you haven't really spoken much today, and then I'll take Jeffrey, and I'll come into the room.
Thank you, and thank you so much all for bringing this, because it is fascinating and exciting. And I do think, as Jill says, that we have been able to do some really good things here in Haringey, and I do feel that there's some really interesting working. Obviously, there's always more to do, and really notice in all these different areas that percentage-wise, Haringey does have quite a high number in all of these areas. So I think it's really important. Just, I suppose, a couple of things I was really thinking about. I really agree with and I think as we've learnt with little bits of work that we've been doing with various communities, I think sometimes we need to put additional effort into these communities in order to give people a similar opportunity. I do think the work critically has to be collaborative. I think where we have been working across organisations and we build those relationships so that one individual, one person who's working in one organisation can say, oh, I know who to go to for that. I think that's where we see our multidisciplinary working being really effective. I think it has to be holistic, because I think when you come into contact with someone, you want to make the most of that. I also think, and this is probably a bit more of a primary care thought, but I think what I've been really aware of is with some of these people, actually sometimes general practice is really good at capturing them. And I'm mindful during COVID, when we were first wanting to vaccinate, and with the Roma community, I remember being asked about it, and I knew nothing. I know little now of what of communities that are living in Haringey, but I do happen to know that there's one that lives. There's a group of people who live right behind Lawrence House Group Practice, and actually have quite a good relationship with the practice, and the practice has lots of expertise, and they might well be a good place to go and get some thoughts about. But it is that additionality that you need to give to those communities that is critical. I think and actually there's something, I think that's where there's opportunities for teams with specialism in them and economies of scale. And I do wonder if we are talking about some of the teams we have working with homelessness, and it's not to lump everyone into the same group, because I know everyone is distinct, there might be similar skills you would need in some of these groups, and so there might be ways of doing that. And then I guess the last thing I just wanted to really recognise was, actually, if there's money out there that would enable us to do more work, if we could work together to, and whether it's us or other organisations, we know that we need additional support for some of these groups. So let's think about how we can all work together and contribute to get the right people, or the right groups, the right organisations supporting it, because actually, I think we're quite good at innovation in Haringey when we're given the chance to do it. So I'll get off my soapbox now.
Thanks, Cassie. That's really helpful. Absolutely. Agree wholeheartedly. Jeffrey, and then I'll come to Sharon.
Thank you. I'll try and follow Cassie's motivational speech, I think. So thank you again. Really, really welcome this, Priyal, Sarah, and Jill. And it kind of supports a lot of other work we're doing around tackling health inequalities. So my question, I had three, but down to two, because I think, Jill, you picked up on the intersectionality between race, for example, in some of this work. And I think that's really important, because it's not very clear in what we saw there. And for some people, that's additional barrier beyond what has been written there. My next point then is really more of a basic question, which is, we are targeting migrants. What's the distinction there between migrants and refugees, and why have we drawn the line where we've drawn? So that's the first one. And the second one, in phase 2, we are doing some interviews collectively of these groups. Who is actually undertaking these interviews? Because I think the people and the personality is really very important. Thank you.
I think those are brilliant questions, actually, Jeffrey. And on that latter, I was going to make a point later, but I'll make it now, which was about making sure that we're using all that expertise in the borough and also recognising that engagement is also the journey. So that first engagement can also be part of that journey to break down those barriers, begin to build trust when done effectively and well, but it might need that local face rather than the more general, and just conscious that we, you know, I'm always going to advocate that we make sure the Haringey voice is really strong and that we have that lived experience from Haringey, because what else would I do?
You don't have to worry about that, obviously. We're always stamping our feet to be the first in line for the stuff, as is my custom. Jeffrey, just to respond to your question around the categories, so the inclusion health categories were set by NHS England, so they're not locally defined. So those 5 groups are the groups that NHS England have defined. I think for us, what's important, as you've mentioned, is making sure that we draw out the complexity even within that, and the relationships between the experiences as well, because there's similarities and differences between all those groups. So yeah, really important point, but we didn't get to choose them. On the kind of research and interview side of things, I think Priyal, maybe you could speak to the detail of this, but there's always been that every borough kind of contributes their different bits, and if we have people with lived experience that can speak, then they will, and so we're trying to go with the way that people want to contribute to it, rather than saying there must be 5 interviews in each borough, because some people don't want to speak, so there's a bit of a balancing act there. But also to say that our homeless health response from the outset was always co-produced, so a lot of that co-production and insight has been fed into the work we've done on contributed to the needs assessment as well. Priya, take from me.
Thank you, Jeffrey, for that question. In terms of who carried out the interview, so we had a voluntary sector partner, Groundswell, who are a homeless charity, and they conducted the interviews. So initially, it was supposed to be a peer. It was a peer interview, especially for people experiencing homelessness. But not all the peers they had obviously lived experience of being a vulnerable migrant or of the other inclusion groups. But it was as best as peer interview experience as we could get, knowing that it's best way of doing these interviews.
It's worth noting that that is an organisation that is 70% of their staff are people with lived experience of homelessness, migration, or prison and drug use. So there's a broad section there. So they really are one of the best organisations kind of doing that work in the space. I, though, would like to see us, and I will say this everywhere in the hope that money will come my way to make it happen, create a sort of pool of resident researchers. I think it's actually something that would build capacity within our own residents, but also enable us to work meaningfully with people when we are doing data collection and various different consultations that we do. It also has obviously employability benefits. So anybody who has money, that's something that we will be speaking about a lot over the next 6 months or so. I think it's something we would really like to build in this space.
Thanks, Jill. I think you're spot on. And the point is that this kind of work saves us money, because when we have a difficult question and we don't understand, the best thing you can do is pick up the phone or run a session and sit down and talk to people who know and understand, and save ourselves a lot of heartache and not make all these sometimes unusual assumptions or stereotypes, what have you. And I just put in a little bit of a plea, because I know that Councillor Carlin and Councillor Collett have been really advocating on the Gypsy Roma side of the community and have begun to develop some really good relationships locally. So it'd be really good to see those connected in with this piece of work, again, because the engagement is the journey as well. Sharon's been waiting really patiently, so I'm going to bring her in first, and then I'll bring you Zena, and then we're going to move on.
We obviously went through this report at the Community Health Advisory Board not so long ago, and I spoke to some of our teams at Public Voice Health Watch about this, and we deal through our Reach and Connect work and through our social prescribers with quite large numbers of people that fit into these categories, and they'd be only too willing to try to share with you some of the experiences they have had in advocating for these groups of people. And what they say is, unsurprisingly, is that these are often people with hugely complex and multiple problems that really do need somebody to be advocating for them to get to remove the barriers that they're facing, particularly to health services and social care in particular. So I think you could do worse than go, if you want to interview our clients that come up in the casework, you'd be very able to do that. As you can see, I think now circulated a leaflet we prepared on rights for, particularly for several people that come to us saying that they can't register with the actually do. So please use that leaflet. We can give you hard copies if you would like them to share with other people. But I think one of the things the team said to me is that certainly the Reach and Connect work that we do, that is a limited period of intervention. I think it's a few weeks only, but often they need help beyond that. So looking at how we can commission that help, which will last longer, or these very vulnerable groups of people, would be a sensible thing to be looking at in our commissioning.
Thanks, Sharon. And that's a useful reminder on that access to GP services. That's an example. I guess Sarah and Priya, I'm sure you're aware of how we're trying to really get to the nub and heart of some of the experiences of residents and barriers, and it's part of that picture.
Someone you can talk to.
So, and there's a good offer there.
Thank you,
Tina?
I think this is really interesting and I think this is a really interesting report, and thank you for all that hard work. I just want to say something about Gypsy Roma Traveller. Have some experience of working in East and Central Europe with Roma communities, which I did a few years ago for the Open Society Foundation. So I've got some grasp, I think, of what those communities their experience in the countries that they live in. I was in Czech Republic, I went to Kosovo, I met people from Romania and other Eastern Central European countries, people who suffered the worst racism and prejudice, I think you can imagine, since the 30s, really. And so I think when people come here, they don't often identify as Roma because of the prejudice that they've experienced. So I think we won't know the numbers actually. And so when, for example, we say we've got a very large Bulgarian population here, if unpicking that is something, because we have at North Haringey School a large proportion of Bulgarian children, they speak Turkish, according to their teacher. So, for example, so that raises the question of, are they Roma or what? Where do they fit in Bulgarian society? I say that simply because I think we can do some good local research by talking to some of the head teachers and their experiences. And I think North Haringey School would be a good starting point for that. And there are some other schools which have now got similar large cohort. The other thing I'd say is that there is a school of Romany studies, you might know this, Jill, at Greenwich University. And I think it would be worth us networking with Greenwich University. They've done I just Googled to see whether they published some papers, and they've got some recent papers. And I think that working with the university on this community in particular would be incredibly helpful. And I also think there are probably some local groups. I don't know if you know that in Northumberland Park, there's a Bulgarian Sunday school right by the neighbourhood resource centre. So I assume somebody's gone to talk to them there to see whether you can make some networks and so on, because I think that probably, I'm guessing now, but I suspect there's a big overlap into the Roma community and people from Romania, Bulgaria, where I live. There were loads of Romanians in what looked to me like Romany clothing, used to walk up and down Tottenham High Road, and there was a bus every Friday night coming and going every Friday. It was like Victoria Coach Station. And so I think there's quite a lot of local anecdotal stories and evidence, but also I think we can evidence it better if we worked with people who are academics who really specialise in all of this and draw on the knowledge of our schools.
Thanks, Ina. That's really helpful. And I'd add into that I know lots of members of our food network are engaging with some of our communities who are most on the fringes and often have no recourse to public funds and are relying on our food network for food and that basic support in times of need. So I'm sure they would have, but I know I'm certain that Jill has a handle on these things, and it connects so deeply with knowing our community piece of work. Quite right, opening the lid on. Since we discovered that Haringey has the largest Bulgarian community, certainly in London, if not in the country. So in that in itself, it has helped us identify an unmet need within our community, and then delving deeper into what that community and what it looks like and what it needs. I'm going to bring in Lynette, and then I am going to end this item because we've still got one other big chunky one. Lynette.
Yeah, just wanted to follow up what Cassie was saying about it will take all of us to really engage in this issue and really make a shout out for the grassroots organisations that we're actually working with. So we are part of the Inequalities Fund, and we work with You versus You, refugees and migrants, HOPEC, Bulgarians, Eastern Europeans, or people from Eastern Europe, and Community Cook-Up. So a lot of what we're talking about here, we've actually got grassroots that if we gave them some of this work, or we worked alongside them, would also be ensuring they're still here and they're sustainable and they're available to the exact people that we are talking about now. So just wanted to kind of make a shout out for the grassroots that we're working with, which they've been fantastic. And really growing in their confidence to reach into their communities and understand the issues. So it'd be really great if we can also work with the people that are already in our borough doing this work, like some of them tirelessly, day and night, not even a 9 to 5. So yeah, really just wanted to make a shout out for the brilliant work that they've been doing alongside obviously Jeffrey at Bridge. We've been working with those groups and they've just been fantastic. And actually that work started with Community Protect. So they also wanted to go on that journey with us to ensure that their communities were going to be informed, kept safe, etc. So it'd be really good if we could utilise the expertise we have in our borough.
Thanks.
We definitely are. I have to go now, but just wanted to say we definitely are. Some of those organisations are getting bits of funding in for this space out of the Equalities Fund and from my services already. But you're right. What isn't clear in what we just presented is that is a big and important part of this. Thank you for championing your colleagues. I really appreciate that, Lynette. I've got to go, but thanks so much. Thank you.
Thank you. And it is a really important point that you're making, Lynette. And also we have to recognise and acknowledge that sometimes these organisations, they're there when nobody else is. Sometimes there's nobody else. Sometimes we're not there. They are. So it's a really vital point you make. Okay. Well, thank you, Bill and Sarah. I hope we've given you enough of input there on, and I'm sure we'll hear more on phase 2. We look forward to it and giving a bit of an update on where you get to, and it'd be good to hear a little bit more about some of the organisations and people with lived experience you engage with, particularly in Haringey. So thank you.
Thank you very much.
I'm going to straight on to the next item. So we're on item 10. We're nearly there, everyone. The schools health survey and healthy schools approach, and I think we've got Susan and Linda here. Susan, are you starting?
Yep. So I'm just going to briefly introduce it and then hand over to Linda and to Sophie, who will quickly go through the presentation, because I'm aware that some of you in the room have seen this before at the Community Health Advisory Board, where I presented it, but we've just done a couple of tweaks to a couple of slides, but overall it is the same. So it's just to give you a flavour of the range of organisations and partners that support schools in Haringey to improve the health and well-being of children and young people and the wider school community. And also the presentation shares with you some of the highlights from the health-related behaviour survey that we carry out. And this provides us with a really good, rich, qualitative data source of children and young people's voices. So I'll hand over to Linda, and Sophie will put up the presentation and we'll quickly whiz through it for you.
Thanks. Could I suggest, I know that there's quite a lot of important detail here, but if we could just so we make sure we've got enough time for discussion. So give us some highlights, assume that we've read, and in particular, I think probably really interested in what some of our young people are saying. It's probably my steer as much as anything, but I know it's an important piece of work. So give us the highlights, and then we'll go to the discussion, please.
Good afternoon, everybody. For those board members who don't know me, I'm Linda Edwards, Senior Public Health Commissioner for Children and Young People. So I sit in the public health team. So I'm just going to quickly put some context to our presentation. For obvious reasons, schools are well placed to work with a range of services to support them in adopting a whole schools approach. And these approaches should have a positive impact on key areas such as healthy behaviours, health inequalities, social inclusion, and ultimately improving the achievement of children and young people so that they could achieve their full potential. So everything we do is evidence-based, and the evidence shows that education and health are closely linked. So we really want schools to promote health and well-being of children and young people, so that we improve the education and health and well-being outcomes. So next slide, please. So this is really just to highlight to the board some of the services, activities and programs that are being offered to schools, not just individual schools, but across the school community. And it requires a high level of engagement and partnership working. And I've included on this slide safeguarding because it's everything that we do with children, we know that is underpinned by safeguarding. We want children in the school setting to thrive in a healthy environment, but also to feel safe, not just in the school setting, but in their home and in the wider community. So that's, I'm going to stop there and hand over to Sophie, our program, Healthy Schools program lead, who's going to talk us through quickly the voice of children, what they're actually saying about their health and well-being.
Thank you, Linda. Yes, I'll try and whiz through as best I can, but yes, you can have a look at this in more detail at a later date. So hi, yeah, I'm Sophie. I am the Healthy Schools program lead and I am within the public health team. So today sharing some of the results from our health related behaviour questionnaire, which takes place every 2 years in Haringey. So it's carried out with primary and secondary age pupils in the borough, and we work closely with the school's health education unit to deliver and analyse this survey. At this time, we covered 35 schools and just under 4,000 pupils. We included special schools for the first time this year. We had a small sample size from the special schools, just 2 schools participated and 36 pupils. But this is the first time we've included special schools, so it's useful to look at the data and consider this for the next time. As Susan said, the slides to follow are really just a snapshot. We have a lot of analysis and many wider topics covered in the survey. Here's just a map of the schools who took part, so you can see quite an even spread across the borough. Okay, starting with emotional health and well-being in primary age. I'll just pick a few bits off the slide. So how happy are you with your life at the moment? Boys significantly more likely to say that they were very happy with their lives at the moment compared to girls. No significant difference between boys and girls who reported very unhappy or not very happy. Looking with a comparison to previous years, pupils were less happy in 2022 compared to the 2 previous years of the survey. Looking at emotional health and wellbeing in secondary. So this is a question around worrying and top problems and worries for students. So on the right-hand side there are the top 5 worries being stats and tests, schoolwork, homework, the way you look, gangs and crime. Compared to previous year of the survey, people are significantly less likely to worry often about gangs, crime, knives and guns, the environment and terrorism. However, worrying has increased on SATs and tests. This question is around feeling safe and trusted adults. So we're looking at both primary and secondary on here. So 59% of primary and secondary both said that they always have a trusted adult they can speak to. And of these pupils, 77% in primary and 60% in secondary said that this trusted adult that they can speak to is somebody within their school. More primary pupils said that they didn't have a trusted adult this time compared to the previous survey as well, with no difference in secondary school on that. Looking at equalities and inclusion, we asked a question around, no matter your background or identity, do you believe you'll be treated fairly and equally by, and then these different organisations and groups. So the smallest proportion of pupils agreed that the police would treat them fairly, and just over half of students thought their teachers and classmates would treat them fairly, no matter background or identity. Doctors and health professionals were the highest on that chart. Looking at physical activity as well, both primary and secondary on the same one here. How many days last week were you active for at least 60 minutes each day? So primary school students significantly more likely than secondary to have been active every day the previous week, so for the full 7 days. The majority of primary school pupils were active for at least 60 minutes every day the previous week, and in secondary it was more common for 3 days the previous week. A snapshot of the drugs and alcohol responses. So looking at primary year 6 only, 4% of primary were certain that they know somebody who uses drugs. Secondary, we had 10% who were certain. And then looking at alcohol use and understanding in secondary, a quarter of students said that they had drunk alcohol before, but only 0.4 saying that they had drunk alcohol regularly. Smoking and vaping as well. So this is something we're looking at the moment. In secondary pupils, this shows the percentage and number of students who smoke cigarettes or vape e-cigarettes occasionally or regularly. And this has increased significantly compared to the previous survey, which I think we all know. Looking here at healthy relationships, I won't go through because there's lots of categories. But this is around romantic relationships in secondary school and how behaviours are between boyfriends and girlfriends. The largest proportion said that their partner had been angry or jealous when they wanted to spend time with friends. 47 students said that their current or past partner had hit them. In this area, we have offered a lot of support for schools on sort of RSHE, PSHE topics and VORG and healthy relationships over the past few years. We have workshops going with schools and also training with the VORG team as well, delivered by Solace in this area. And these results have fed into all of that. Now to look at some special school results briefly. So how happy are you with your life at the moment? And over 2/3 of people said that they are happy with their life at the moment, but do bear in mind that the sample size is very small for this group. Similar to the other question around worries, pupils were asked whether they worry a lot. 13 said yes, they worry a lot, and 13 said no, they do not worry a lot. The main reason for worrying was family, and then followed by environment and then friendships. We also asked if they knew who they could talk to if something was worrying them. The largest proportion said that they would speak to their family, followed by teachers. I think this is the final chart. So looking at safety and more PSHE topics again in special schools, the majority of pupils said that they had been taught about keeping safe online, covering the topics on the right-hand side there. 12 people said they had not been taught about talking to people online who they don't know in real life. Okay, so thinking about next steps for this survey and related work. So myself and Susan and others within the team have been sharing results internally, externally across the pathway. If there are any forums that you think we haven't attended, then please do suggest. I'm always happy to share as far as we can. Schools all receive an individual report with a comparison to the borough so that they can work on specific areas. We encourage schools to look at their results and also provide feedback to pupils. We do have one primary school at the moment who's doing exactly this, addressing areas where they are perhaps lower than the borough on average, and they're thinking with us how they can address those areas and then work with pupils on that. We are also working, another example is with Kerry May from the Anchor approach within public health to produce assemblies which link specifically to the emotional health and wellbeing results from this survey as well. We link schools in with the wide range of health and support programmes available, and the survey links very closely to our core public health work. So, for example, the strategies on the list there. We're in the early stages of developing the next survey for 23-24. Want to make sure that we include all the topics we need, maybe add a few new ones in there, and also to increase the school participation. And I think that's the last slide. Thank you.
Thank you very much. Looks very useful and very important feedback. So thanks to the team pulling that together. I had a couple of observations before I opened it up, which is that for me, I felt thinking about some of the items that were on there strongly raised the question around mental health and wellbeing. And I know Lynette's had to leave, but I felt like there was a real strand. And when we talk about all those worries and some of the other issues there, really strongly. As you were presenting that, I guess I was thinking as a counsellor, but I could take that hat off and think as a parent. And I wondered about our parents and engagement with them on some of these, on their own awareness. And of course, our families and our communities face a huge amount of pressure at the moment and have for some time on many of the issues we've talked about today and beyond. So actually, then alongside that, we can't separate some of the challenges that our children might be facing too. And I felt there's quite a lot there still to explore around VORG. We have a programme, but talking a lot bit more about that and about healthy relationships. I know we've got lots of work in train, but I think, it'd be good to have that conversation. Just some sort of thoughts for me around what I came out strongly, but there's quite a lot there actually, and all of those. I feel like every slide there, we could have a lengthy workshop just on there. And it does raise the question. I think we talk about this before, forgive me if we did, about taking some of this to the Youth Advisory Board.
Yes,
and have really good
and we
conversation.
will. Yeah.
It's really motivated and brilliant bunch of young people who really, I think, want to get, and they've talked to me before about some of the issues that are here. So seems like a good idea, but I'm going to open up, sorry, just waffling on now. Rachel.
I had a question about race, ethnicity, how people identify, and whether there's any way of triangulating any of this with that kind of lens, particularly around all aspects, feelings of safety, mental health and well-being. And the other thing I just wondered was about qualitative, just focus groups. I was quite surprised by some of these results, if you like. I was particularly surprised by the low numbers reporting drugs or smoking or alcohol. And I just wondered whether you would get a fuller conversation through a focus group And particularly if you could do those focus groups around particular community groups, that would be really interesting. I think would really help our understanding.
Yeah. I think just to answer a few of those points, the Youth Advisory Board will certainly share the results, but we'll also ask them about shaping the next survey that Sophie said that we're due to carry out in the autumn of this year, because, you know, it's good to get their point of view on the type of questions to ask. In terms of ethnicity, the full report is also attached in the agenda pack, and we have got data around ethnicity. And then what we've done is we've also drilled down further in the results to do that triangulation. So we haven't presented it here, but we do have all of that data and all those results, Rachel. And when we've been to certain groups, you know, we've you know, shared other groups, we've shared some of that information, but we can provide it, you know, afterwards as well. In terms of the, as you said, surprise in some of the responses, we have to remember that this is self-reporting. This is children and young people self-reporting. So there is going to be some under-reporting, and there may be some over-reporting as well. So, you know, and we make sure that, you know, when we're talking with the schools have taken part in it, or you know, sharing the wider report, that we stress that point, that this is self-reported survey by the children and young people, but it just gives a really good kind of snapshot for schools to have further discussions in their PSHE lessons, in their assemblies, as Sophie mentioned. So it acts as a really good conversation and curriculum starter for schools, definitely. Thanks.
Thank you. And I think the point around how we explore the data more, how we have conversations about the detail there is well made. And we look to the Youth Advisory Board.
Yes.
That's here. Councillor Brad was quite right. You said we don't talk, housing doesn't feature, nor didn't feature strongly, I think, there on, but I wonder that might be an area for future exploration. It's certainly an important factor in young people's lives. So I think that's a good point. And I also do wonder if we might not want to take this survey to the people board, to our people board, for us internally, to just talk a little bit about some of the content and what we might want to do. Gary, sorry, I did see you earlier.
No, that's fine. Thank you, Chair. I think you're right. I think we could probably focus a session on each of the individual slides and what's been reported. But what struck me a little bit was the reporting on illegal drugs. I think it was 28% of year 10, so 15-year-olds basically, who are in contact, who are fairly certain that they know someone who uses illegal. I mean, that's quite striking, isn't it?
Yeah.
Drug bit, but also the illegal criminal activity in itself. Is there anything more that you can share on this concerning that, about what the breakdown may be, or is that just a basic percentage in terms of the self-reporting? It's just, this strikes me as quite high.
Sophie, I don't know if you want to come in, but if I could just say that we now have the Combating Drugs Partnership that Will chairs, which is a requirement of us getting additional money like other local authorities. And within our action plan, there's a whole section on children and young people and what we are going to support various settings with going forward in terms of the education and the raising awareness and the intelligence gathering. So Gary, it's definitely further on our radar in terms of, you know, engagement and getting more information. Yeah.
That's
Sophie,
great,
I don't know if you...
I was just going to say, that's the key, not to be drawn into that world, I guess, from that point of view. And I suppose with my mental health hat on, and then the number of incidents we have with drug-induced mental health crisis, it's something that is quite prevalent. So yeah, the resource to try and educate on that is obviously a priority. Thank you.
Yeah.
Well, thanks for the floor. Thanks, Gary. My only other question was, presumably do other local authorities do these surveys, and it might be good, don't have time now, but just to understand how we compare with others in London, even if it's not the same methodology, etc. But it'd be interesting to other what some of our comparator boroughs.
What does the school's health education unit who carry out this survey on our behalf and do the analysis, you'll see in the full report that they always have sections on our comparators, our neighbours. So they do this survey with lots of other local authorities across the country, and they look for our, what's kind of known our statistical neighbours, and then they do a comparison. So there is some of that comparison in the full report, which is, always useful to see.
Thanks, Susan. Peter.
I was so pleased to see that you're asking the question about vaping. It's amazing, isn't it? It's a triumph of advertising and product placement that this activity, with no real long-term safety evidence, but certainly plenty of evidence of the amazing addictive property of nicotine. And these are young people who are not old enough or in the right age group where vaping could have been used as a way of giving up smoking. So it's really quite remarkable, and it seems to have really crept on the population with very little awareness that we've basically allowed this to happen, to generate thousands of addicts, really, who probably, many of whom will be addicted to nicotine for a lot of their life.
I think that's right, Peter. And actually it chimes with a lot of the anecdotal. So what I've been hearing in the borough is a lot of parents of the children at secondary school describing, and you might say a triumph of product design, because the fact that they're flavoured, they seem designed in the flavoured, in their whole spec, they're designed to attract young people. Will, do you want to comment on this?
Yeah, it would be good to provide some more information on vapes, because most of the vapes that kids secondary school age using don't contain nicotine. I'm not saying that's better, but it is kind of almost like a gateway, and the regulation of products with nicotine and without nicotine is different. So there's quite a lot of nuance, and then there's the environmental impacts as well. Right. It's crept up, hasn't it, with particularly in the pandemic?
Yeah, it has.
So I just wonder, I mean,
Very visible.
how much parents really, well, actually, community generally, parents having a role, understand some of that.
And we're hoping to do some work on this and do some active research with our young people about their knowledge of vaping, the harms, also the illegal sales and the counterfeit sales as well, because it's the same as tobacco as cigarettes. There's a very big market for counterfeit sales as well. So we are hoping to do some further work on this this year with our environmental health colleagues and trading standards colleagues as well.
Thank you. So I'm going to give the last word on this one to Sina.
Yeah, I think this is really interesting. A couple of points. Number one, I do think that not asking about housing is a gap, because if you're living in overcrowded conditions, it's not going to do much for your health. But I think there are some other areas which strikes me and missed out. We could ask people if they read books. Do they go to the library? We ask them about, do they do sport? But not every physical activity. We're talking about physical health, but in emotional health, intellectual health. We want people to read, and so at least I do. And so I think it's sort of by omission, we're not thinking about that type of side of being healthy. So that's one point I wanted to make. And the other one was, I was struck by the things that they said they were most worried about. And I wonder if this is because of the fallout from the pandemic, where they said boys and girls both were most worried about SATs and tests, which not surprised that it's high, but I'm surprised that crime is as low as it is, and I'm a bit sceptical about that. Certainly from going around secondaries and talking to young people recently through social workers in schools, I think people are very anxious, quite fearful. And that's obviously a tiny, tiny micro sample. But I'm just wonder about that. I suppose if you put knives and guns, gangs and crime, you're going to get 25%, 22%, 21%. So you might want to bunch that lot together.
Yeah.
Yeah. So I think that's quite concerning, really.
Yeah.
And more. Sorry, go ahead, Susan.
Well, I mean, we'll certainly take forward your suggestions of additions for this year's survey in the autumn. Yes, we will.
You know, can we ask how if they go to the library? We're investing a load of money in libraries.
Yes.
Really, you know, the programme that came out of the Christmas holiday, I thought they'd really push, even though Wood Green got to fix their lighting, it has, you know, they've gone up a notch. They really have. And I would like to see if we are promoting that. Young
Will
people.
do.
Thanks, Nina. It's really helpful.
Just very quickly, in terms of building on what Zina's just said, could we ask them about the extent to which they go out of the area? I think there's sort of geographical aspect.
I agree with that. Absolutely.
So often ignored, and we know that some of our kids, they've never seen the Steve.
They've never been to, they've been in town. They've never gone up the West End.
I think we need to know about those things in terms of the quality of their lives, and also whether they have any engagement in the community. Do they do any voluntary work? Are they involved in the
What do they do in the holidays?
Somewhere, some measure of the extent of whether we can measure their engagement in the community in any way.
I think
they have to do anything for anybody else.
That's what it's not a quality of life indicator.
These things are as important.
I agree about that.
Things that we've been inquiring about. Anyway, sorry to.
No, I think that's. I think that's they're really interesting points, aren't they, Susan?
Yep, all very helpful. Thank you. Really appreciate it, and we'll explore them for the next one in the autumn. Thank you.
Thank you. Thanks to the team. So very quickly, we've got 2 more items.
Oh,
not yet. Okay, we're 1 minute over. I'm sorry. It's all because you're so brilliant. That's why. So future agenda items and meetings. So at the moment, there's a slight error there on the next meeting of the joint Health and Wellbeing Board and Community Safety Partnership. That isn't next week. That date's TBC. And then we've got our next Health and Wellbeing Board in March, when we're focusing on mental health. I've got a long list of other things. And of course, after March, we're then into the new council year with all that strangeness. And so we haven't got any dates there yet, but we will do. And my long list goes like this: workforce, toilet strategy, in no particular order, perhaps a question around capacity in the voluntary sector within the remit of health and wellbeing. I had one on maybe in the summer thinking about winter. So perhaps reflecting on sometime when we're a bit away from the heat. That's not a very good analogy, but anyway, of the being in winter, to reflect back and think about the future as far as it's possible. I think digital isolation is still a really important issue, and some partners are working on. So that's one for me. Modern slavery, as I said, is a bit of a theme at the moment, and as well Vogue. I wondered if at some point we might hear just a kind of composite of Health Watch's perspective on the last year and a coming year. Well, that might be quite interesting, and LTNs too. So that's a list in no particular order. Other items are fully possible. Send them through. Always keen to add. And Will had an AOB on.
Yeah, just quickly, we would like to inform you that we're going to update the health and wellbeing strategy for Haringey. So this was last done as just before the pandemic. We had a strategy with a Start Well, Live Well, Age Well framework. Never actually went through the formal consultation because of that. It's really timely now because we've got the Borough Partnership, the ICS population health strategy. What we'll do is we'll bring a bit more of an update in March after the item setting out the approach, but would like just a permission to kind of start even speaking to individuals about the process in between, so we can make some progress. The plan is that it will be very action focused, so some really specific things that we're going to do and outcomes we're going to achieve, and we'll capture the work that we're doing in the borough partnership as well. So we'll in effect act as that kind of strategic plan for the borough partnership.
Could I just, on the next meetings about mental health, could I ask that we have something about housing when people leave the hospitals, or after they've been sectioned and all that stuff, and ask and what the options are and what the management of it is. And Lucia said earlier that every councillor will say, "Oh, I've had a terrible case," and they are so terrible. I have one. I sent, I must have been 100 emails about one person, and it didn't get resolved till one officer just decided they would listen to the plea from the community. And it's the most difficult area, but I think it would really help, be good to air it across the agencies and have housing at the. It's not about having housing there really, because it's about HMOs really, but what the housing options are and how it's done through. And the other thing, if we talk about mental health, we're going to talk about children as well as adults.
So,
hope so.
Yeah, so maybe we can refine, we can work out the scope.
Do you sort the agendas out? I didn't know. You're the eminent. You're the brains behind it.
No, I just, I think it might be useful for us to define the scope before and actually have a bit of a conversation. And
it's huge issue.
May want to.
There's a little bit of work to do before then.
And adults, I don't know how we do it, because I think they are very closely linked, but there's also some separate nuances to the two issues, and it's a separate group of people for CAMS, etc.
Yeah, it's a huge issue, isn't it?
So noted, and thank you, Lena. And I think we were saying to Will, yes, you do have permission to go forth and then bring back something to the next meeting. Thank you all. We're only 6 minutes over.
Be fair.
Thank you. Bye.
And the housing, because I mean, the thing is, I can't drive.